Okay, good evening to you all, and I welcome all the students and faculty members and colleagues who have joined today evening for Yashoda Hospital Masterclass session. As you know, Yashoda Hospital brings these interesting masterclass session for all the critical care graduates and trainees who are undergoing across the country. So we have a wide range of topics that are being discussed on every Tuesday. So we today have an interesting case scenario of pancreatitis complicating with an extrapulmonary condition reason what is causing the ARDS in this patient. So to present this case, we have our students who are doing their critical care fellowship at Yashoda, Dr. Ramprasad Bhupatiraju and Dr. Misala Karthik, who are pursuing their IDCCM here at Yashoda. And to take through the course, I'll be moderating the session. And we have an elite panel of experienced examiners today for us. Dr. Sharmili Sinha. Dr. Sharmili is a senior consultant critical care medicine at Apollo Hospitals, Bhubaneswar. She's an associate professor in critical care and general secretary elect for ISCCM. As well as I welcome you, Dr. Sharmili, for today's session.
Thank you. My pleasure.
And we also have an elite panelist, Dr. Balasubramaniam. Dr. Balasubramaniam heads the critical care unit at Medicover Hospital, Secunderabad in Hyderabad. And we are glad to have you, Dr. Balasubramaniam, today on the panel. We welcome you to today's session.
Thanks, Karthik.
So, without wasting much time, we will dwell into the topic. So, the case is on a scenario of a young male who presented to us with a condition of acute pancreatitis and which complicated into multi-organ failure condition and how he recovered. So, pancreatitis is a very, very important condition which we see day in, day out in our ICUs. Sometimes it is very mild or stable in its presentation, but sometimes it can be haywire and it can be very, very catastrophic when patients land with multi-organ failure. So we'll see this case scenario today, and I would request Dr. Ramprasad and Dr. Karthik to take through the scenario, and Dr. Sharmili and Dr. Balasubramaniam will be guiding them through the case. Over to you, Dr. Ram.
Good evening, everyone. Today case presentation. Chief complaint, sir, a 34-year-old male working as a software engineer hailing from Hyderabad presented with complaints of sudden onset severe abdominal pain for about 2 hours and complaints of 3 episodes of vomiting in the past since 2 hours. History of presenting illness. He presented with sudden onset severe epigastric pain for about 2 hours. The pain was dull aching in character and radiated to the back. It is associated with 3 episodes of non-bilious, non-projectile vomiting consisting of food particles. There is no history of fever or loose stools or constipation, no history of headache or yellowish discoloration of the eyes or urine. There is no history of hematemesis or melena. Past medical history. There is no similar complaints in the past. Personal history: normal bowel and bladder habits, normal appetite, no loss of weight. He was a non-smoker, but he takes occasionally alcohol, and this last intake was 1 week ago. Family history: no history of similar complaints in the family. Drug history: no significant drug history. General examination: patient was conscious, oriented to time, place, and person at the time of examination. No pallor, icterus, cyanosis, clubbing, or pedal edema was examined. Vitals on arrival to the emergency department were BP of 200 per 110 millimeter of mercury, pulse 103 beats per minute, SpO2 97% on room air, respiratory rate 24 cycles per minute, temperature was febrile, GRBS 172 milligrams per deciliter. Systemic examination. On inspection, there was no abdominal distension. The skin over the abdomen showed no discoloration, no dilated veins or sinuses. Umbilicus was inverted and to midline. Auscultation. Bowel sounds were slightly decreased. There was no broods or no venous hum. Palpitation. Epigastric tenderness was felt. Associated with guarding. No obvious organomegaly. No signs of ascites.
Fine.
Other system of examination were in normal limits.
Yeah, so we'll hold on to this
Yeah.
slide. We'll try to. Can you summarize what are the positive findings in this case in terms of
Yeah.
history and examination
Most,
findings?
yes, that mostly he was a 34-year software employee who mainly came with complaints of epigastric pain and vomitings. The pain was radiating to the back, and on examination, he was conscious, current oriented. BP was 200 per 110 millimeter of mercury, probably hypertension because of pain or an accelerated hypertension, but there was no end organ damage or any other organ damage. I won't call it an hypertension emergency, probably accelerated hypertension. Then on examination, there was epigastric tenderness, which was associated with guarding rigidity over that area. But there was no any obvious organomegaly or there was no clinical examination of any ascites.
So,
So,
Dr.
Yeah.
Ram, at this point of time, what are your differential diagnosis and provisional diagnosis with this much of clinical information?
So after the history and examination that we did, our initial diagnosis, most probable diagnosis would be acute pancreatitis, considering the characteristic pain and associated vomitings. However, it could also be acute cholecystitis, which will have more pain in the right hypochondrium. However, it can also be in the epigastrium. And other DDs that I would think of is intestinal obstruction, though the vomitings were non-bilious in this case, and he also doesn't give an history of constipation. Other diagnosis would be acute porphyrias. He is an young male with sudden onset acute epigastric pain with vomitings. uh, and ACS should also be considered. Though he is young without any comorbids, nowadays we are seeing in younger population. So chest pain can be referred to the epigastrium, and in some cases they can also have vomitings. Other diagnosis would be even aortic dissection. However, hemodynamically yeah, that can also be a possibility considering the very high blood pressures.
Blood pressure.
Yes.
What about the possibilities of gastric ulcers, gastric or duodenal ulcer?
Yes, ma'am, definitely could be there, ma'am. But
There's a
though he
subcutaneous.
would have mentioned some history of epigastric pain on and off in relation to food, this is more of acute without no significant history in the past, ma'am.
No unnecessary intake.
Yeah, even without a history, also it could be it's comes high on the differential. One of
Yes,
this gastric ulcers, either duodenal or the gastric ulcers, plus minus perforations, right? So acute. You mentioned about the possibility of acute coronary syndrome. Which kind of type of acute coronary syndrome usually present with this gastric predominant gastric features?
inferior wall MI can have radiation to the epigastrium, ma'am.
Right. And this is a very characteristic also, like the blood pressure was 200 by 110, such high diastolic blood pressure, and heart rate is not so high, as disproportionately, I mean, as opposed to you would find it with now normal pancreatitis, 108. So there's a possibility of undiagnosed essential hypertension is also there, though it may not be emergency. In that context, that abdominal aortic aneurysm diagnosis actually comes little higher.
Yes, ma'am.
Yes.
Otherwise, in most of the cases, with this age of young of 34-year or software, uh, usually this degree of hypertension is not only proportionate only due to pain, cannot be attributed to pain only. Could be a component of essential hypertension, maybe undiagnosed and till that point of time.
Yes, ma'am.
Okay.
what
Yeah,
about perforation peritonitis?
Uh, uh, Based on history, that is a very good possibility, sir. But on examination, the pain is more localized to the only to the epigastrium, sir. Uh, Not generalized rigidity and
Any other negative points?
negative points for perforation, sir.
Yeah.
Hemodynamic instability.
He is hemodynamically stable
Stables and
and
BP is high. In perforation, mostly they will have hypotension.
Yeah.
So one thing, and in history wise, there is no history of constipation or anything. So this is the negative.
Mm-hmm. Okay.
so there is no history of fever, right?
no,
No,
ma'am.
ma'am.
No history of fever. So this conspicuous any acute abdominal conditions Also, I think acute appendicitis, though it will be low in the list in this case, given the site of tenderness and epigastric tenderness and associated guarding, still atypical acute appendicitis at this age is also a possibility to complete the
What
list
about
of differentials. Yeah.
abdominal angina, mesenteric infarcts or something?
Centric ischemia could be a possibility, sir.
Because
Ischemic
Also,
sudden onset, you have a high blood pressures. Okay, you're a young guy. I mean, we don't know. You said there is no bruit. Okay,
no, sir.
but
Yes, sir.
still, I don't know. I mean, at this point of time, you're saying only epigastric, but still an abdominal angina, mesenteric ischemia. All things are still. I just keep it in my differentials to rule it out,
Okay,
unless
sir.
other is done.
absence of fever is very conspicuous in this case. Usually, one of this, the top 4 5 diagnoses, you would expect at least one episode of fever or at least febrile. So his temperature was completely normal. Now, what does it say? What does it signify, or it's not significant?
The absence of fever here rules out most of the infectious causes, ma'am. Say what we have discussed, cholangitis or cholecystitis. Usually they will have fever, and also peritonitis. They also may have the infectious causes. They are usually present with fever, and even fever is also common in pancreatitis. But considering his very early presentation, that is within 2 to 3 hours of onset of abdominal pain, he may not be well into that CIRS response yet, inflammatory response.
Yes, so that is probably that also explains the heart rate being not so high. It's less
Yes.
than 110. So yeah, please proceed here. Next slide. Actually, you did there was a focus done. So what
Yes.
was the purpose of focus in this case? How do you think it would be helpful in the assessment and management?
As the patient is having high blood pressure, we want to rule out is having any pleural, any pleural effusions, or probably is having any axial hypertension causing pulmonary edema, or we
So
want to see LV function, whether he's having, we are suspecting any ACS, so any RWMA is there or not. We want to rule out, and if any well examination, we would miss any free fluid. For that also, we want to get a focus at this point of time.
So, given the presentation and the assessment of the clinicals, his vitals, apart from the blood pressure, which is on the higher side,
Yes, ma'am.
his breathing is fine, his saturation is normal on room air. So, I do not think hypertension will be looking for pleural effusions at this point of time. It's a bit early, isn't it? There is no respiratory decompensation at this point of time, and LV function. Probably, are you worried about the cardiac function for anything? Just because of the blood pressure, or you want?
Because of the blood pressure and the pain, mostly in the epigastric, suspecting we're thinking of inferior wall MI. So we want to see what double the RV function, LV function,
One thing is
RWM.
we would like to see at RWMA in lines with ACS, ma'am. Second thing I would like to look at is the any features of concentric LVH or diastolic dysfunction. That essentially tells me whether he is a known hypertensive or undiagnosed hypertensive, or this is probably secondary to the pain, ma'am.
So, given the options that again, on the third one you mentioned about abdominal findings, so minimal free fluid in the pelvis.
Yes.
So, given the options of looking at the cardiopulmonary aspect with the focus and the abdomen, what would be more informative and useful in this case? Would you be inclined to look at the assess the heart and the lungs at this first go in this case, or you would be focusing more on the abdomen?
More on the abdomen, ma'am.
More on the abdomen, because I do not think so. I mean, we know that we are very getting used to and comfortable with focus these days, but given this presentation, he has heart and lungs at this point of time and do not have, and ACS is not very high in the list of differential diagnosis. And if at all we have to suspect and pinpoint a diagnosis of ACS, ECG, 12-lead ECG, as common as that, would be the first thing I would do rather than putting a focus to look for wall motion abnormalities.
How
Free
did you
fluid.
look at IVC? How did you look at IVC? Is it transhepatic or subcostal?
Subcostal, sir.
With that severe pain, did he allow you to put a probe there?
He has probe tenderness, sir. I mean, we didn't indent the probe much. Superficially, we could see, sir. It is easy. He is uh, not. There's not much of fat
Came
tissue
with
there.
that severe pain. One of your differential is pain to cause a accelerated hypertension, and he allowed you to put a probe there. That's what madam is trying to tell you. And probably ECG the first thing. Echo at this point of time, yeah, as you said, I mean, probably second, third, stitching and close. I'll do an ECG at the starting. That's what madam is trying to tell you.
We did that, sir.
No, that's good that I mean people are getting more used to focus. But what I tend to tell you is during your examination presentations, try to keep it this somewhere later in your presentations. If you after your clinical examination you just straight go to focus, because we are not looking at pulmonary edema, pleural effusion. We are not worried about the heart and the lungs right away. But abdomen, there is something you might look at. Some of the collections, perforations, fluid-free fluid collections. So you can actually pose it accordingly, according to your case scenarios. Yeah, yeah. Please next proceed.
Yes, ma'am. From the Eastern examination, our provisional diagnosis like acute pancreatitis, acute
We've
colitis.
discussed this already. Yeah, I think.
Yeah.
Yeah.
Next, my friend Ram will take.
So these were the initial investigations from emergency, ma'am. His hemoglobin was 15, PCV was a little bit on the higher side, 48, TLC were elevated, 22,000, platelets were fine, creatinine and BUN were fine, electrolytes were within normal limits, and liver examination was also fine, ma'am. LFTs were normal. MLAs was around 1,100, lipase was around 10,000, ma'am. Both triglycerides and calcium were within normal limits. Official 2D echo was done that showed no regional motion abnormality, normal LV function. ECG was fine, ma'am, with no STT changes, normal sinus rhythm. USG abdomen was done, which showed feature size 2 of acute pancreatitis with grade 1 fatty liver, ma'am. And ABG was done, which showed lactates of 2.4, pH of 7.37.
So, what is the
Sorry, ma'am.
so what is the diagnosis now? The revised diagnosis. You can
Yes,
pinpoint more.
based on this clinical presentation and reviewing the labs and imaging, we can confirm this as acute pancreatitis, ma'am.
Yeah. So, what are the criteria for just to consolidate the
It
criteria?
is revised Atlanta classification for diagnosis of acute pancreatitis, ma'am. It has three parts, which is first one would be characteristic abdominal pain, and the second one is our biochemical markers, either MLAs or lipase elevation more than 3 times the upper limit of normal, and the third one is imaging. Here in this case, we have all three. Any two would be sufficient to call it as acute pancreatitis.
Yes. Right. So,
Imaging, is it ultrasound based or is it CT based?
CT or MRI. Imaging is
Cross
CT or
sectional
MRI.
imaging.
Then we don't have all the three, right? We haven't done a CT.
Yes, yes.
I have only two, right? How many are required for you to label it as an acute pancreatitis?
2 is enough. So
Yeah, that I can accept. You can't say 3 out of 3, right?
so next.
So the initial management.
One second, Ram.
Yes.
You
Yes.
said ultrasound was suggestive of features such as acute pancreatitis. Can you tell me what are the ultrasonic features of acute pancreatitis?
There is a gross enlargement of the pancreas, sir, as per the
Okay,
ultrasound.
so at this point, what you can find is a bulky pancreas,
Yes, sir.
right? Are there any gas shadows? Because in your X-ray, I can find the gastric air bubble
Gastric
over
air
there.
bubble.
So with that in situ, it's going to be slightly tougher when you're looking for either for IVC or for an ultrasound to look out for a pancreas. Okay.
Yes.
Yeah, many cases actually, in contrast, I mean, this case does not have any distension, as Dr. Bala is rightly saying. There'll be gaseous distension of the loops are there. Usually, it covers the pancreas, and it is usually concluded as correlated with CT. It's but what would be more useful information to obtain from the ultrasound abdomen in this case,
To
apart
rule
from
out the cholelithiasis or cholecystic
yes,
Good.
gallstones.
Gallstone.
Because ultrasound are the imaging of choice for detecting the gallstones, both on the biliary tree, gallbladder, pancreatic duct, anything for that matter. Yeah. So lactate is little high, 2.4.
Yes.
What do you think it is due to? Is it normal or?
No, ma'am. It's a little bit on the higher side, but he don't have any hypotension. There's no say liver failure or anything.
So what it could be due to? It's not very high, but it is
Probably,
high.
though the BP is fine, there can be some end organ hypoperfusion, ma'am, because of the SIRS response. Maybe that is the reason for the elevation of the lactates, I believe.
Can you tell me
So there
what
is
are the components of SIRS response does this patient have at this point of time?
Components of SIRS response. One is heart rate more than 90 that this patient has. Second is respiratory rate more than 20 that also this patient has. Third one would be uh, TLC, which are more than 12,000. This patient has. Fourth one is fever, right? That this patient doesn't
Temperature
have.
is
So he
normal.
has 3 out of 4. More than anything more than 2 is positive SIRS response.
Okay.
Should I proceed, sir?
yeah, next.
Thank you. So the initial management that this patient got in the ER is first one, fluids were given. Both initially a bolus of NS was given, and later on RL. The bolus was 10 ml per kg, followed by maintenance crystalloids at 1.5 ml per kg per hour was given. Pain management was done with injection tramadol, and patient was initiated on prophylactic antibiotic ceftriaxone 1 gram IV BD. Oral antihypertensive medications were added, and patient was also concurrently started on NTZ infusion in view of hypertensive urgency, and it was titrated according to the PP. Anticoagulation was started with injection enoxaparin 40 mg subcut OD. Injection thymine was started, and patient was shifted to ICU for further management.
Are you
Uh,
okay with NS as the initial fluid?
uh, Actually, RL was preferred, sir.
Okay.
Uh,
What was its weight?
Sir,
What was the patient's weight?
around 75 to 80 is there, sir.
So they gave 800 ml of water. I mean, the saline or RL, that's it.
So initial bolus NS was given, sir, 500 ml. His bolus dose comes out to be around 800 ml, sir. So 500 ml NS was given, followed by RL of 300 ml, then followed by RL was continued at 1.5 ml per kg per hour, sir.
Why do you need a bolus at this point of time?
Though his BP was on higher side, because the recent waterfall study states that if patient is hypovolemic, then we should give a bolus of 10 ml per kg, or else we can straight away start the dose, maintenance dose. In
Is
this
he
case,
hypovolemic?
uh, but IVC was collapsing, sir.
He
There
has got
can be,
severe pain. He's got severe pain.
yes, sir.
Okay. Probably he's also breathing fast as per you. Okay. Then
Yes,
is IVC reliable at this point of time?
yes, sir. That could be a confounding, since he is little bit tachypnic also, IVC can be collapsing, sir.
Hmm. So, say the water. Can you summarize? I mean, I think you're trying to tell me about the waterfall trial. No?
Yes,
Can you
sir.
summarize what exactly
So,
waterfall trial told
so
us?
what they did was they took patients with severe acute pancreatitis, and they randomized them to two groups, sir. In one group, they treated with aggressive fluid resuscitation, which is 30 ml per kg, followed by 3 ml per kg per hour in all the patients. In the second, 20 ml per kg followed by 3 ml per kg per hour. In the second group, what they did is they will initially assess the patient whether he is hypovolemic or not. If he is hypovolemic, they gave a bolus of 10 ml per kg. If he is not hypovolemic, they straight away start a maintenance dose of 1.5 ml per kg per hour. So
Okay.
the study was concluded early because of utility in the aggressive fluid resuscitation group. So based on that, the current guidelines, even the 2024 AGA guidelines, have stated that we should go ahead with moderate aggressive fluid
Yeah.
resuscitation, then rather than over aggressive fluid resuscitation.
So, probably, I mean, do you accept with this bolus at this point of time, or you don't accept?
I mean, based on IVC and we gave, but it could have been avoided, sir.
Mhm. Okay. So,
So, at this point of time, as he rightly said, IVC could be fallacious
Yes.
because of this pain, and there is tachypnea and a spontaneously breathing patient. It is
Yes.
difficult to assess, right? I mean, his pain is probably mounting, and he's on the tachypnea side, so it is difficult to assess. Number two is also actually what about hypovolemia? In this case, is it an absolute hypovolemia or a relative hypovolemia that you would tend to treat with fluid resuscitations?
It's there will be third space loss, ma'am, because the capillary leak increases and fluid goes into the third space. Where in this case, the intravascular volume gets depleted.
So there is a relative hypovolemia in this case. I mean, so it would actually not be unwise to give a small fluid bolus as between around 5 to 10 mils per kg, because there is a benefit of doubt. We do not know, and it's very difficult to extract also history from most of our patients about the extent of fluid therapy that would have already received. If he had presented to your hospital, which is a tertiary hospital, is an educated guy from Hyderabad, but many patients do come from Perigat. They go to some smaller hospital, district hospital, and then get referred to the tertiary bigger hospital. So how much they have received, they not received, it is difficult to assess. And that's what probably 2.4 of lactate was probably a kind of indication that that could be some degree of relative hypovolemia and organ perfusion probably slightly compromised, though in the initial stage, according to the history he has presented early. So it would not be unsmart and unwise to give a small fluid bolus, which you would have given, and then you are following it at around 1.5 mils per kg per hour. As far as fluid choice between RL and NS, yeah, RL is actually balanced salt solution.
Yes.
As opposed to all this, expensive one which is available in the market, like all the company names we know, it is RL is a desi. It's a very much a balanced salt solution existing for decades. Normal saline, though it is branded in many, I mean, what I'm not going to the discussion, but it's also, if you do not have RL, you can also use normal saline, because the hyperchloremic acidosis which we talk about, probably up to 3 to 4 liters of resuscitate fluid if you have given. So something less than 1 liter, if you're in an emergency, you can give, but switch on to a more balanced solution as soon as possible. Yeah. What about the pain management in this case? Are you happy with this injection tramadol?
Initially, that was given, ma'am. Later on, when the patient came to ICU, we started him on fentanyl infusion.
So what are the problems with the tramadol? I mean, there is nothing right and wrong. It is according to the availability and people's choice. What are the issues with tramadol as a pain
It
relief in
causes
this
nausea,
patient?
ma'am. It can aggravate the
Yes.
vomitings.
It is, if anyway, these patients have a tremendous degree of nausea and vomiting tendencies. With
Yes.
tramadol, it's usually the normal dose is around say 100 milligram. You are giving IV 6 hourly or 8 hourly. It adds to the problem. And what do you think about opioids as analgesia in these conditions?
Opioids, they have high propensity to cause paralytic ileus, which is also common in patients with acute pancreatitis. So we should be wary about giving opioids, ma'am.
So then why was he started on fentanyl later on in the ICU?
Yes, ma'am.
So why do you think so? Have fentanyl, all opioids will cause hypostasis and paralytic ileus? What doses do opioids cause paralytic ileus? Have you what all kind of opioids have you used for pain relief in acute abdominal cases or acute cases in ICU?
Fentanyl mainly, ma'am.
Fentanyl is one of the rapid acting and more potent agents. Also,
Okay.
you have morphine, we have nalbuphine, right? So this is a myth actually that opioids cause, not only it's a myth that it causes paralytic ileus. It can cause biliary sphincter spasm, as we used to study during the pharmacology days. So it's a myth. Actually, they are very good, potent analgesic agents and cause pain relief. And most of these patients, if you speak to them, there are two major complaints in the initial 5 to 7 days. One is the nausea, vomiting. Second is the pain. It is tremendous. So it is actually imperative to give them good degree of analgesia. And opioids are actually good ones. The ones that were available, the fentanyl, the nalbuphine one, the patches are available. They're very good. They do not cause paralytic ideas per se. And all the guidelines have mentioned it clearly. So this is, it's a forgotten myth actually. So it can be given
Okay.
along with what about NSAIDs?
Besides, we can give, ma'am, but we should also look at the creatinine values they all because of the hypovolemia and third space loss. These patients already have a increased risk of AKI, so we should be wary about that, ma'am.
All right. So that is, SOS you can keep for very severe pains. If you are not relieved, then you can give. Otherwise, you can give. What about paracetamol?
Can be given, ma'am.
Can be given, yes. Because I see some of our colleagues, gastroenterologist colleagues, also have reservations about using paracetamol in cases of pain related to abdominal cases, but it's absolutely safe. It's nothing to
Maybe
do
in
with the
alcoholic
toxicity.
CLD, they must be very.
Yeah.
toxicity.
What about this antibiotic cetraxone?
Yes, ma'am.
Was it
No, it
what's the
was not
rationale?
indicated, ma'am, because
Mhm.
most of acute pancreatitis, even though fever, elevated TLC, everything, it could be a CERS response. And
Mm.
most studies have pointed out that there is no role of prophylactic antibiotics.
What is the worry? What is the challenge issue? Concern
What
about
it does
starting
is it
antibiotic at
will,
this stage here.
if we start prophylactic antibiotics, that is actually detrimental because it promotes the growth of resistant bacteria.
Correct. So you have given antihypertensive NTGs, anticoagulation with enoxaparin.
Yes,
Or it was given started at emergency itself.
yes, ma'am. He has started.
So what is the DVT risk calculation for this patient on presentation?
Actually, no, no, not immobilized. Could be avoided. Wells would be zero, ma'am.
So and there's nothing right and wrong. We are just discussing because I would think like it's probably not necessary at this point of time. He does not seem to have organ
48
dysfunction
hours we
yet.
can.
Yeah, so at least you can wait for 48 hours. So, you know, right. You've written some scores here. What are the scores?
So these are the severity scores for acute pancreatitis, ma'am. The first one is BISAP score, which this is the only score which we can. I mean, this is a score which we can do at admission uh, within the first 24 hours. So it has five components. One is one more than 25. Second one is impaired mental status. Third one is CIS response, which this patient has. Fourth one would be age more than 60, and fifth one is presence of pleural effusion, ma'am. Any score more than 3 would be suggestive of severe acute pancreatitis, ma'am. In this case, he has score of only 1, ma'am.
Oh,
And
which is good for him. That is mild. Yeah.
sorry, ma'am.
Mild pancreatitis. This one.
Yes, ma'am. Yes, ma'am. As per BISAP, it is ma'am. So,
Ranson's also that the criteria you should know. You did not elaborate now. I think you can proceed, Dr. Bala. If you agree, you can proceed. Yeah.
Yeah, a small concern. What was the hematocrit in this case, Ram?
48, sir,
48.
on admission.
Do you think that was important in this patient?
Yes,
Did it
yes.
give you any information? You mentioned about it. Probably in fluid resuscitation part, this discussion happened. So, what cutoff hematocrit tells you that there could be hemoconcentration in pancreatitis?
45, sir.
More than 45.
Yeah, anything 44 to 47 and above is a sign of hemoconcentration, right? So you have to watch hematocrit. Did you follow up the hematocrit?
Yes,
The
sir.
Yes,
next.
sir. After 48 hours. After 48 hours, we saw it is decreased.
Okay. Fine. Yeah, we'll continue.
Thank you, sir. So after arrival to the ICU, this was day two. Patient was started on fentanyl infusion at 50 mics per hour in view of persistent severe pain. Fluids were continued. RL was continued at 125 ml per hour. NTG infusion was tapered off after the initiation of oral antihypertensives. By the evening of day two, patient developed hypoxia, requiring nasal prongs with 2 liters O2 support. And by this time, the cumulative fluid balance was around 3,600 ml. If you look at the labs on day two, we can see that both HB and PCV were in the downtrend. That is good, and BUN was also decreasing. So both of these tell us that we have resuscitated him adequately. And one issue here was the lactates were in the increasing trend. From two here on day two, the lactates increased to 4.
So
So
what do you think is the reason why the lactate would have gone up? No.
again,
Did you do a LFT? Did you see any baseline
yes,
LFT was normal?
normal, sir.
Normal. Okay.
What was the lactate? I can't see actually in the screen. I don't.
Lactate is 4, Dr. Sharmili.
But it has increased. Okay.
It has increased. Yeah, it has doubled almost. Yeah.
So what do you think is the cause?
Again, could be peripheral organ hypoperfusion.
Mm-hmm.
Was he
And
on
so
any drugs?
No, no, ma'am. No, sir.
No. Okay.
No, no drugs that can cause hyperlactatemia, no type B
I
lactic.
mean, any past medication history you took, right? There's no
Yes, sir.
medication
No, no
history.
medications in the past.
Okay.
Should I proceed, sir?
now we developed hypoxia requiring oxygen and the PO2 on the blood gas was? 68. This is on 2 liter of oxygen.
Yes, ma'am.
So what is the PF ratio? 2 liter nasal bronchs. What is the FiO2 and what would be the PF ratio? It appears less, isn't it? I mean, it is less. But what is you need to know the corresponding, the oxygen supply and the point FiO2, the mask, and then increasing 1 6 liter, 8 liters, high flow mask.
Yes.
No, how much FiO2 would you take for a 3 liter with the nasal prong? You have given 3 liters, right? 2 liters. How much would it be?
Room air
Around
is
21.
21%. So
Around
2
30.
liters.
0.3.
So what would be the PF ratio?
About 200, ma'am. If you take it
Yeah.
as 30, 68 by 30 would be, uh,
Yeah, around that. Yeah.
yes,
So
Around 200.
yeah. So what would be the possible causes at this point of time of
one
hypoxia?
could be the, because he is in 3600 ml of positive fluid balance, could be mild pulmonary edema setting in, ma'am. Others, since we know that he is a case of acute pancreatitis, the there can be some pleural effusions that are developing, ma'am.
So this is on day 2, no?
Yes,
Yes.
ma'am.
And how much was his urine output? His
Urine
TNC, I
output
mean,
was adequate, ma'am, around 60 to
adequate. Still,
70
he was
ml.
in a balance of almost 3.7 liters
Yes,
on
ma'am.
the second day itself.
Yes, ma'am.
So this is a point actually how you can evaluate him as the cause to ascertain the cause of hypoxia. What can you do to assess the cause of hypoxia?
Uh, uh, we can uh, we can again do an we can check if the IVC, look if it is dilated. We can send an antibro BNP if he is going into heart failure with pulmonary edema.
What
Uh,
about focus? Can you do a quick ultrasound to look
yes,
at?
yes, we can look at pleural effusions. We can look at B profiling in the lung. Uh,
Yes, because
Sorry,
earlier your
Ram. I
part
mean,
was clear. Yeah.
Ram.
yes, sir.
Right from day one, you have been hell-bent on saying about pleural effusions capillarily. Do you think, I mean, in the acute pancreatitis on day one, you'll have capillarily?
No, sir. That is
On day two?
no, sir.
Mostly after 48 hours.
Okay.
By
So why are we running after capillary leak over here? I mean, so you said you're giving fluid, you want to restrict moderately aggressive, you want to give it at 1.5. So if I take him 80 kgs, so around 120 ml per hour. So your 3600 ml is your total intake is IV fluids is what is going to come in a day. Only IV fluids. So how can he be thin? That means he is not producing any urine output.
no, even
His cumulative balance.
sir, initial bolus dose was given, which will be around 800
800
ml.
ml. Okay.
Then followed by
Okay.
125 ml per hour was continued. That is
So
2400 ml plus I think another 600 ml. So
So total
3000
comes
ml.
around 3,800. I will take it
Yes,
4 liters. You are
and
given
he
4
also
liters.
yes,
Okay.
sir. He also had some IV medications going on, sir. Like thiamine.
Ceftriaxone,
Yes, sir.
thiamine.
Thiamine,
Okay.
ceftriaxone. So
Okay.
his
That too, you
output was
said it was
adequate.
OD, right? So you said output was adequate. Okay.
Yes.
I take it at least more than zero point 0.5 mils per kg. So 80 kgs, more than zero point 0.5 is close to
40
about
ml.
40,
40
50
ml per
ml
hour.
per hour. So that means you're getting somewhere between 900, 1200 ml. If you're giving 4 liters of fluids and then an output of 1200, so I'll not see positive balance by 3700. Okay. So probably, I mean, someone would have given some more boluses somewhere.
Yes. I think when
Okay.
Possible, no?
lactates were in the increasing trend, there must be some
So
pulses.
despite fluid boluses, your lactates are going up. So how do you want to approach now?
So because of could be peripheral this thing, sir. Peripheral hypoperfusion, sir.
Why? What's his blood pressure? Sorry, I didn't see that. I missed out.
BP was on the higher side, sir. He was initially
Okay.
BP was on arrival was 200 by 110, sir. He was
You're
started on
saying
multiple
there's
antihypertensives, and now it came down, and now he's on NTC was weaned off. He's on antihypertensive medication, sir. Oral drugs.
no. You said peripheral hypoperfusion, right?
Yes, sir.
So how are you saying that it is peripheral hypoperfusion? How are you coming to that point?
Because there is no other obvious cause, because there is no such one more possibility could be, sir, he could be a known hypertensive with baseline higher blood pressures. Once we have started on NTG and brought his blood pressures to lower, that could be his way below than his baseline blood pressure, because patients with chronic hypertension, they develop this
Yeah, I
peripheral.
accept all the hypotheses, but how are you going to evaluate is what I'm trying to ask. So you have a lactate of 4. Now, how do you want to go furthermore? How do you want to look at it? So as per
uh,
you, the PF ratio is about 326, and you said he is developing hypoxia, requiring nasal bronchs.
yes, sir.
So can you substantiate your words and your answers?
Yeah, I mean, like, you go back to history, you might find one more reason why lactates would have been elevated in this case. He was occasional alcoholic.
Yes,
Phenolic, yes, sir.
yes.
Yeah. So in
He
India,
had a
occasional
binge.
means you have to take it with a pinch of salt, right?
He had a binge.
Yeah.
Probably.
So how do you could have an explanation there as well, but I think
Because
you're already
CLD,
correct.
when the lactate clearance decreases, that also leads to elevation in lactate levels.
CLD is a very
CLD.
late stage. I mean, like, you could have thiamine
Inequitable.
deficiency, right? You could have that as a reason for elevated lactate level as well, considering his history of alcoholic intake, right?
Yeah,
Probably you could
thiamine is one good
substantiate.
important thing there.
Did you check for his, or could you check for the CRT, capillary refill time? Is it necessary? I mean, it would be helpful.
Yes, so that is a very good marker for peripheral perfusion, ma'am.
So his peripheries were warm, or was it been checked, or like CRT?
Didn't check CRP, ma'am, but peripheries were warm only, ma'am, not cold.
Yes, 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 yes. Okay, so there is some indication that there is some perfusion issues is there. We're trying to figure out, these are the all possibilities that we are talking about. There
Yes,
is some problem there. Of course, the rising lactate, persistent lactate not clearing and increasing is obviously, as a point of concern in this point of time. And now he's requiring one organ dysfunction he has developed, that is oxygen requirement. Here,
yes,
probably, as you said, the focus you can do to see if any new thing is developing in his lungs, the cardiac, and with the NTG requirement ongoing and higher blood pressure. Also, is he going into a kind of, if not systolic or diastolic heart failure, which is we are just discussing? There's a component of heart failure in this case also. While you
yes,
are giving as a fluid resuscitations for the third spacing and relative hypovolemia, also this patient might be having a long-standing hypertension, though there is no LVH or concentrating LVH. So it's a mixed situations. It's a complicated situations, but I think we just continue the supportive therapy and proceed here. So next, what did you do? Next,
sure. Okay. So day 3 again, if we look at the labs here, his PCV has shot up along with hemoglobin. Both went up, and even there is an increase in BUN, and creatinine shot up from zero point 0.5 to 1.7. Uh, Considering he's going into third space losses and he's going into hemoconcentration, fluid boluses were given, and maintenance fluids were increased to 150 ml from 125 ml. His urine output was adequate, 60 to 70 ml per hour. By this
Now,
time, he didn't.
can I stop you here? On the other side, you said he is positive balance by about 4 liters. Since
Yes,
there is an increase in hematocrit, and I think couple of slides back, you have told us about the waterfall trial
yes,
and the reason why it got stopped because of futility to safety, right?
yes.
Okay, and you want to increase because the hematocrit has gone up. So after the waterfall trial, the guidelines have made clearly sure not to go for a larger volume resuscitation, even if your hematocrit is going up. They said go for, if you are hypotensive, go for an aggressive vasopressor usage rather than fluids. So can you tell me your rationale for increasing fluids?
Uh, since I think now the labs and his clinical condition clearly states that now that capillary leak and third space loss has started, sir. Because by second day we have seen some improvement, and again by third day, all our labs showed that there is uh, hemoconcentration. Uh, so we didn't give such big boluses of 10 ml per kg, sir. Small boluses of 300 ml like that were given, and we just increased the maintenance fluids, sir.
So, I
And
mean, can you tell me the concept of fluid creep here?
sorry, sir, fluid.
Fluid creep.
It goes into the third spaces because of capillary leaks.
Mhm. So if I'm giving 150 ml per hour, again, we'll come back to your same equation. So that's about 3600 ml of your intake. Okay. And your urine output is about 60 to 70. I'll take it 70.
Yes, sir.
This thing. So for 24 hours, it's going to be around 1500 close about. Okay. So that means you are adding another 2 more liters of fluid into the third space, particularly into the abdomen. So you expect his abdomen to become better or worse? You can see the
Intra-abdominal
day
pressure.
3 of your lamps as a reflection of your fluids. And your oxygenation is also started to go down.
Yes, sir.
Do you think, I mean, probably you would have revised your fluid strategy over here, not just basing on your hematocrit?
So at this point also, what about the temperature and the heart rate?
Uh, uh, Heart rate was fine, ma'am, around 100 like that. There was no temperature, ma'am. He didn't develop any fever spikes, ma'am.
No fever spike with all this going on.
Not
Yeah,
later he developed, ma'am, not by day 3.
not the.
So
So this is
again, the new issue here was he developed abdominal distension, and by this time he didn't pass stools for 2 days, and bubble sounds were also sluggish. We placed an we shifted him from for CCT abdomen, ma'am, on day 3. I'll just show the video.
Um, okay.
Yes.
yeah, it was visible.
We are trying to play the.
Let's not play it. Yeah.
What is the explain?
One second. The video isn't playing.
No, you explain the CT findings.
Okay.
Yeah.
So, CCT abdomen was done, which is suggestive of severe acute necrotizing pancreatitis with peripancreatic fluid collection, ma'am. And they have given a modified CT severity index of 10 by 10, ma'am.
So now two things. The patient has developed now acute kidney injury. What are the causes of acute kidney injury in this case?
One, because of the pre-renal, ma'am, because though in overall fluid balance is positive, intravascular volume will come down. So pre-renal would be one cause. Second, could be secondary to that CIRS response, ma'am, because there will be a cytokine storm that goes and it causes end organ damage, ma'am.
Yeah, and also if you use an essential hypertensive, it appears to me that taking day 3 also requiring NTG is probably an undiagnosed essential hypertensive. There could be a baseline nephropathy as well in this case, which
Yes.
has now added to the problem. And do you think day 3 was it a bit early for the CCT abdomen, or it could have waited and probably little bit later?
The
With that rate.
uh, the guidelines suggest that we can do anywhere between after 48 to 72 hours, ma'am.
So it was on day
Mhm.
3, right? On the day 3, it
Yes,
was
ma'am.
done.
So post
Right.
48 hours, we have taken him up for CT. The reason being the abdominal distension. Also, so
So
we have a better idea
look
of
for
that.
the cause.
Yes, ma'am.
What was the abdominal girth? Did you monitor that? I mean,
Yes,
did you start monitoring for abdominal hypertension,
yes, yes.
intra-abdominal hypertension?
We monitored for abdominal girth, sir. I didn't include the values here, sir.
Thing is, say when I'm looking at it, you're giving 150 and he's passing only 70. So more than half the fluid is still retaining in somewhere in the abdomen over there, or somewhere in the tissues. Okay, so you're adding more. If the abdomen is going up, is that the reason for your AK? On top of that one, you have
Yes.
given a contrast also. No.
Yes, I mean, after this value, this is prior to contrast. So this creat of 1.7 is prior to contrast. And as you mentioned, there can be yes, sir, because venous congestion could also cause AKI, sir. Uh, so that
Okay.
can also be there, sir.
No,
Do
see,
you
in all the
define
three parts, before giving fluids, can you look at anything other than IVC for giving fluids?
Vexus we can do, sir.
See, nothing on the abdomen side, anything on the cardiac side. Could you have looked at VTI variability and then give fluids? Will it help? I'm just asking.
LVOT VTI, sir.
Yeah,
Yes, sir.
you were thinking he's hypovolemic. Okay, if he's hypovolemic, probably VTI. And nowhere you would have mentioned that. Neither when you're suspecting something as a cardiac dysfunction, diastolic dysfunction. I don't see a VBG or looking at an SCO2, particularly in presence of your elevated lactate. Or you're not looking at that because you wanted to send pro-BNP and other things. You're not looking at venous gas. I mean, when you're suspecting cardiac, is heart involved or not?
Uh,
I think they have done baseline echo. It was normal at that point of time,
I
and
saw that.
yeah, so they didn't suspect any cardiac involvement at this point of time.
Because one of the differentials they are looking at diastolic dysfunction um, and inferior wall MI and other things were going on. I think I got
Yes,
disconnected for a
yes,
couple of periods.
yes,
Yeah.
so?
yeah.
How do you just I think it's a very interesting case. So, Dr. Ram, and so how do you define intra-abdominal hypertension?
so
From the
intra-abdominal.
exam point of view, I just want to touch few points, and we'll then proceed here.
Yes. So intra-abdominal hypertension is intra-abdominal pressure more than 12 mmHg would be intra-abdominal hypertension, and anywhere more than 20 would be abdominal compartment syndrome.
So syndrome is defined with the pressure and what else?
And with end organ
And
damage.
organ damage.
Right. So would you like to do, so you have done a CT, though creat was little higher. I think, given a choice, I would probably, probably you're worried about the distension, but if it is not too high, it is expected, isn't it, with the diagnosis of pancreatitis? Probably I would wait for another day or two. There is no urgency to do especially when you're considering to give a contrast and patient's hemodynamics are stable. I mean, probably, the young fellow would like to contain the organ damage. And would you like to go for an intra-abdominal pressure monitoring in this case?
Yes, ma'am, that would be helpful.
How do you do that?
First, we place the patient in supine position, ma'am. We will drain all the urine out of the Foley's. Then we'll connect a transducer to the Foley's, and we inject around 25 to 30 ml of sterile saline, and we'll check the pressures. And we should check the pressures at end expiration.
Right. So do you do that in your unit or regularly?
No, ma'am, we didn't do this in this case.
Right. I think we can proceed if others do not have
Uh,
questions.
what's the last question? I mean, started on Unnastatin. Why do you want to start Unnastatin?
Because it is a, the stat, there's no clear cut evidence considering evidence suggesting the use of ilnostatin, but theoretically it has some anti-trypsin, anti-proteolytic enzyme activity. So some fewer
If you
studies
want
have
to, if you want to start, what is the timeline where you want to start? Okay, and
within the
at
yes,
at this point of time with the two organ failures, I mean, you have PF ratio on down, so probably hypoxemia as well as AKI. Okay, can I start it or am I late?
ideally it should be started within the first 24 to 48 hours, sir.
Mm-hmm.
This is already day 3. It showed
Anything in
some
relation to organ failure before the onset of organ failure or after the onset of organ?
before
What does
failure.
it decrease if you are using it?
Decreases organ failure, sir.
So once you have a set organ failures, does it have a role?
No, sir. Not no, sir. Probably.
We'll go
Okay.
forward.
Yes.
Yeah.
Yeah, Ram, you have to quicken up. It's already 8.
Yeah.
So day 4, his hypoxia worsened and patient was initiated on HFNC support with 50% FiO2 and 50 liters flow. Now, by now the cumulative balance was around 9,900 liters. IV fluids, we came down on the IV fluids to 100 ml per hour. Patient has intermittent high blood pressures during this time. We start intermittently. He is required NTG support, and we are suspecting whether he is a case of essential hypertension, which was undiagnosed. So we did a since he is an young male, we did a renal artery Doppler. However, that didn't show any renal artery stenosis. And by as we said on day two, we have also placed an RT. The RT aspirate was around 400 ml. Seeing the labs again, we saw a good fall in hematocrit, and counts were coming down. Creat also improved from 1.7 to 1. There's also a fall in 1. And the problem on day 3 here was worsening hypoxia. Lactates also came down, but the PF ratios are in the falling trend. Should I proceed?
Yeah.
Yeah.
So
Yeah, we can
day
finish
five,
also.
sorry,
Yeah.
ma'am.
Yeah, proceed, please. Yeah.
So by day 5, the cumulative balance was around 10 liters. We stopped IV fluids and HFNC support. He's requiring HFNC support. The abdominal distension was still present. He hadn't passed stools despite of laxatives and enema. And RT drainage was continued. Day 4's RT aspirate was around 1600 ml. By day 5, since we couldn't start oral feeds, we have started him on TPN at 50 ml per hour for his nutrition. And we did a X-ray erect abdomen. Though it didn't show any air fluid levels, it just showed gaseous distension of the bowels. His potassium was also normal. We are suspecting paralytic ileus at this time. Labs were okay. Creat was all again in the downtrend from 1 to 0.7. The PF ratios were also in a downtrend from 180s to 140s on day 5. So day 6, looking at the poor oxygenation, we went ahead and we did a HRCT thorax, which showed a moderate left effusion and mild to moderate right pleural effusion with basal collapse consolidation. There were subtle GGOs in both lungs with mild interstitial thickening, features likely suggestive of pulmonary edema. On day 6, HFNC support was continued. Patient has 2 episodes of low-grade fever spikes of around 99 and 100. On day 6, patient has passed stools. And here we when we did an ABG, the PF ratios were very low, around 109. That is the reason we did a CT thorax for him. And here there was a plan to we have involved pulmonology, and there was a plan to do pleural tapping, but due to some technical reasons the tapping could not be done on day 6. And uh, this is the CT. So day 7, HFNC was continued. We saw some improvement in the PF ratios on day 7. On this day, we did an ultrasound chest to screen for the amount of effusion. It was around 300 to 400 ml on the right side. The decision was made by the pulmonologist to wait since his PF ratios were improving. He passed stools twice, and the abdominal distension also decreased on day 5. So, RT on the day, sorry, day 7. The RT aspirate for day 6 is just 120 ml. So we clamped the RT and we started him on oral sips of water, and we also continued TPN. Lab,
Any specific reason you didn't start enteral feed here in this
uh,
patient?
this is the day where the abdominal distension has just come down, and that is the reason we just wanted to give some sips of water and see if it tolerates.
So this is actually, I mean, these are the cases actually you can start it a bit early, just
Yeah.
kind of trickle feed something, after those initial 72 hours, you can start some trickle feed if it's not full feed. I agree with this partial supplementation with the parental nutrition, but holding it till say D6, 7 is probably not necessary. And pain subsiding being taken care, antiaspirate not so high, less than 500 ml. So actually, enteral feed or to some, we call it trickle feed or less amount, can be started a bit earlier than day 6, 7. That is one of the important interventions and recommendations, isn't it? It's one of the myths also, which is not to be followed. Yeah. So for this continued, I think the concerns I see is about the HFNC, the organ support.
Yes.
Apart from the fluid, and it is so pancreatitis, acute severe pancreatitis is one of the important causes of non-cardiogenic pulmonary edema. And hypoxia is the predominant presentation. CO2 UC is fine, so ventilation is not an issue. And in these cases, apart from this capillary leaks are there, and there's a lot of shunting due to the pleuroperitoneal canals. Also, the patient is constantly supine with the distended abdomen, that is basal atelectasis. It disproportionately causes VQ shunts, which is responsible for this degree of hypoxia. So, in these cases, actually, just physiotherapy and spirometry, if the patient can, with good analgesia, it has got tremendous value. We have seen patients. And in fact, actually, I would prefer to give some of this positive pressure in these cases. Though HFNC theoretically gives around say 8 millimeters of mercury, we talk about it, but some positive pressure with the with the airtight pressure also helps to relieve this basal atelectasis, expand the lungs, and reduces the shunts. So these are the we have managed few cases like that, and I would prefer in such some of the selective cases would I prefer NIV compared to HFNC in such cases. Yeah. Please proceed if you do not have other questions.
Ram,
Yes.
I mean, say suppose, like as Karthik asked, I mean, if you want to start feeds, this thing, and someone comes and says, why not put a, I mean, why not to start trickle feeds if it's not already put a post
Nasovaginal feeds.
nasovaginal feeds? Did it? Is there any difference? Do you think is it still uh, being practiced? Or do you want to do it? What's the present consensus?
Regarding nasovaginal feeds, sir.
Yeah.
No, the guidelines have mentioned that there is no difference between nasogastric, though there is a theoretical advantage because it passes the pancreas, that prevents the stimulation of pancreas. But they suggest both are basically the same, sir. Whether nasogastric or nasovaginal, anything can be started, sir.
No, I'm saying across if you want to start an early feeds, you're having a high RT aspirates.
Yes, sir.
So your gastroenterologist comes and says, no, I'm going to put a nasogenin and then start feeds. Are you okay with that, or do you want to still wait? How do you want to proceed? Is the question that.
We'll wait. So there's no reason to place a nasovaginal feed tube, sir.
Mhm. So what will be the reasons for you to place an nasogenin tube?
When the gastric motility is very low, or when the patient has recurrent vomitings, uh, those are the indications. When the patient, especially when the patient doesn't tolerate nasogastric feeds, and when there is high risk of aspiration, nasovaginal feed would give us some advantage.
I mean, your patient is having a high RT aspirates doesn't mean that the gastric motility is on lower side.
By this day already, the RT aspirate has come down, sir. He also passed to the
No, I'm
abdominal
saying
dish.
about a day prior. I'm not saying when it decreased. A day prior,
Yes, sir. It
if
was
he asked what are your answers for con, saying that no.
no for nasovaginal tube, sir.
Yeah. At this point, the consensus statement doesn't recommend nasogastric or nasogen. There is no difference in that.
Yes.
Doing a procedure in him with someone who is hypoxic is going to increase the risk of him going onto the venti. So I will hold on. I will hold on for a day or two. You're maintaining anyway partial nutrition with your TPN. Okay. So I'm
Yes.
okay with that.
Okay.
Okay, proceed. Yeah.
So day 8, on this way, patient continued to have fever spikes. TLC were also on increasing trend, 14,000 to 19,000. We have sent blood cultures and serum procalcitonin, and antibiotics were escalated to injection xenon. Uh, TPN was continued at 50 ml per hour because we have started him on oral feeds, but that was not adequate enough. He passed stools, 2 episodes were there. Then oxygenation also improved on day 8. PF ratios were around 158. And the Procol that we have sent came out to be 0.29, which is negative.
Now, I have one question over here.
Yes.
So I have been seeing right from day 5, you have been doing CRP every alternate days. I think 500, 340, 305.
Yes.
Okay. Now you have sent a Procal also. Okay. What is the source of sepsis that you are looking at this point of time?
Uh, Fever spikes with elevated counts on day 8, I would look at, because it is a case of necrotizing pancreatitis, I would think of this
No,
infected
CECT
necrosis.
showed necrosis, sir.
Sir?
CECT showed necrosis.
Yes, sir.
No, you said only collections, no? I mean, was there a necrosis? I probably would have missed that slide, sorry.
CCT showed necrosis, sir.
Okay. Hmm. The first CECT, what you showed, was showing only peripancreatic collections, right? You didn't comment
No,
anything about necrosis at
no,
that
sir,
point.
no. The CECT which was done on day 3, it showed acute necrotizing pancreatitis with the peripancreatic collections, sir.
Okay, sorry, I missed out. Yeah.
I would think of infected necrosis, sir. So that is the reason we have escalated antibiotics to carbapenems.
Okay, continue.
So on day 9, patient was his oxygenations improved. Patient was weaned off HFNC support. He is maintaining on face mask, and by this time his oral feeds have he's taking the oral feeds adequately. So we have stopped TPN also. A right tube was also removed, and his CRP is in the downtrend. Creat, bun, and TLC were also in the downtrend, sir. And day 10, patient was shifted to ward and weaned off O2 support and discharged a day later, sir.
So, what is the role of CRP? Doing
Uh,
do we need to do
CR,
it alternate day, every third day, something like that?
it can aid us in telling, I mean, aid us in suspecting whether there's any infection. Ma'am. What they say was it has better role after 48 hours rather than early CRP. Ma'am.
So it's an inflammatory marker and it's a high grade state of inflammation with acute necrotizing pancreatitis. So it's
Yes.
got to be high. So it does not have any prognostic or therapeutic value in these cases. Actually, we may, and with this patient's course with the one organ dysfunctions and otherwise his vitals remaining stable, I think it will be we can do without CRPs because from the cost point of view, so there's nothing right and wrong. Procalcitonin, you're rightful in doing it on day 7 when fever persisted. And again, the fallacy is like it is 0.29, less than 0.5, it kind of rules out or kind of makes the possibility of bacterial sepsis very, very unlikely.
Yes.
And having said that, even if it comes high also, that grade of inflammation, it would be difficult to differentiate from the bacterial sepsis versus SARS causing that kind of high inflammation, right? So, in markers are probably not necessary that often to be done because they are also expensive tests, and I think it was managed well. And what kind of TPN did you use? It was a central TPN or a peripheral TPN preparation?
Central. He has a central.
And what about this DVD prophylaxis and physiotherapies that you do? Was it
DVD
a progressive? Hmm?
we continued like Zen, ma'am, and physiotherapy was he was mobilized and chest physio was continued during
Yeah,
the assist.
yeah, I think with the kind of HFNC and all that, it becomes difficult to do this spiros and all. But if you're giving NIV, sometimes even you give them off HFNCs, you can provide chest spirometries and chest physio. The vibrations can happen. Okay,
Yeah.
thank you.
Yeah, Dr. Bala, you want to add anything as a ending note for the case?
I mean, Ram, I mean, one thing what I look at it is we continue to give fluids, making it to close to about 10 liters. Can it justify that? Or if you have a next new patient, say suppose tomorrow you're having similar sort of a patient around. So will you be more aggressive in de-resuscitating this patient at an earlier point, or you'll still want to continue the maintenance fluid concept? What you said
I
on
would
this?
be more aggressive in de-resuscitating early,
Yes,
sir,
sir.
because
Okay.
Will be
So
judicious.
if you're doing a de-resuscitation, what if your hematocrit is going on the other side? If it is increasing,
sorry, sir, I didn't get you.
If you remember.
when you're de-resuscitating,
Yes,
okay,
sir.
and your hematocrit is going up, okay. So how are you going to substantiate your answer there? You started de-resuscitating the patient. I mean,
Yes,
like
sir.
in this patient, despite fluid balance, I mean, on day 3, day 4, you started to have a hematocrit going up, right?
Yes, sir.
Okay. Say suppose you started de-resting at that phase and the next day the hematocrit still goes up further. and Karthik comes back and says, "No, I want fluids." How you want to substantiate your answer and make Karthik accept yours?
We will see the percentage of the hematocrit rise, sir.
Okay, and anything else?
See, even in this case, in the initial 2 days, we saw hematocrit. If you see, the hematocrit was still high even after giving positive balance. So probably anything more than 45, 47 is still what, if you go only by hematocrit, you still feel patient is hemoconcentrated. But as the day 2, day 3 progressed, you have seen that the worsening kidney injury, positive balance, fluid creep, it was increasing, pleural effusion is going up. So probably fluid was over resuscitated. So probably we could have cut down, but only thing that was telling you that fluid deficit might be there was lactate and high hematocrit. So probably this rise in creatinine, rise in your hematocrit and lactate worsening could have been due to your acute pancreatitis, right? The SARS response secondary to pancreatitis. But it's a difficult situation to tell which one is what, and it's not very clear there. Probably clinical decision making would have played a more important role in
Exactly.
this
Well
situation.
taken, sir.
Exactly.
And
Exactly, man. That's
regarding,
what I was. Sorry. Exactly.
yeah,
That's what I
yeah,
was about to tell Karthik. I mean, see, pancreatitis, each patient doesn't behave in the similar way. In one patient, you may need to start aggressive deresin slightly early. In other patient, you need to hold on. Any of the gastroenterologists, the moment you say diuretic, classic, and this thing, they're going to jump on you on the initial part. So you need to be decreasing your fluid creep. Okay. Try to see how much I'm giving, how much is the output. Try to maintain it rather than going for an aggressive deresin with means of a diuretic in a pancreatitis, because it's going to increase your complication risk of other diabetes or other complications. Okay, so that's what you need to be careful. No one pancreatitis patient is similar. Rather, clinical decision making at the bedside makes your job more easier.
yeah, and there's a catch in the calculating fluid balances here, because all the classically what we do is in and out, like whatever has gone in minus whatever has come out as urine output. And especially, I mean, later on he had anti aspirates also, and there's a component of third fluid slurs also, and which is difficult to account for. You can't exactly say how much has will be accounting towards that third fluid, especially when the patient is running high fever. Initially, few days he did not have, and later on he had. So these cases, looking for the signs of end organ perfusion, which is one of the thing is blood pressure, but in this case, patient has an essential hypertension, then urine output, and going for the CRT, capillary refill time. These are the few things, and the patient is conscious. That means brain is perfusing, urine is coming, kidney is perfusing. These are the best way of assessing end organ perfusion at the bedside. And of course, if you have higher means, and if you're well versed with the echo focus, VTI, and other direct or indirect ways of the dynamic indices of perfusion, if you can see that would aid. But nothing. If you must practice this continuous three clinical ways of assessing end organ perfusion at the bedside. Thank you.
Okay. Thank you, ma'am. Thank you, sir.
Yeah.
Thank you.
So, yeah, I'll
Good.
take
Yes.
some few questions before we end. I think we have answered most of the questions that the delegates have been asking. They were about antibiotic change was one thing that the one of our delegate was asking. Probably antibiotic change was required in this case or not. So that's an interesting question. Retrospectively, if you see, probably it was not required, and there was the indication for changing antibiotic to imipenem is only when the necrosis. It's an infected pancreatic necrosis, right? That you have to determine with a culture sensitive or a raised procalcitonin at least, right? So here procalcitonin was slightly raised, but not to the magnitude that you would say it's an infected pancreatic necrosis. We could have waited with that raised TLC count with our previous antibiotic that was on board. But if at all, even that antibiotic is required, if you ask, then in a realistic scenario with that kind of situation and with differential going on in your mind, I think no hospital would be interested in keeping the patient without some antibiotic on the board. What's your opinion, Bala? What do you have to say?
I usually hold on. I'll probably at that point of time where your white cell count is hovering around 18 and 15,000. I would like to look at, because you have kept a center line. Okay, You have a patient who was hypoxemic, is he developing a new? So I'll be more focused on doing a regular focus lookout. Is he developing any consolidations, any line? I'll send cultures, but I'll still hold myself in escalating the antibiotic at that point of time, per se. With one spike of fever on 2 consecutive days, I'll not be jumping on. Uh, Probably a day or two later, I'll again rethink of doing a repeat imaging to see any other thing happening. If something is there, then probably I'd like to see what exactly is happening at the pancreatic bed.
Yeah, even the timing of the CT scan, probably it was more a knee-jerk reaction, probably considering his distension increasing, abdominal distension increasing. We did a CT scan, but whether the CT scan gave us any more clinical details, more than what we have already, whether we could have waited on to the CT scan a bit more and then got it done. Not at that stage was also one point of dilemma that existed, and certainly this dilemma exists whenever such patient comes to the ICU. So that was one more concern that was raised
But you're
by.
lucky. When
Yeah,
the creatinine went up and you gave contrast, it didn't end up in creatinine rising up. It came down the next day, probably because of your fluids or other luck.
yeah, yeah. Yeah, I think we have come to the end of the
Yeah.
questions as well.
There's one question by Pramod. I think CRP is itself a marker of acute pancreatitis. In case MLH is not elevated, other markers of pancreatitis is CRP elevation. Do you want to comment to that? I mean, I just wrote it that CRP is not a marker for acute pancreatitis; it's a marker of inflammation. Do you want to add anything more to that?
Yeah, I think we have already discussed it about
Discussed.
CRP. Yeah.
Okay.
It's got to be high. So, and either it is 120 or 300. I mean, it's got to high, and so 4 to 6 week course. So it's remaining going to remain. It's not doesn't have any therapeutic or
Yeah.
diagnostic value in these cases.
And ulnastatin also is not a recommended intervention or a management strategy except for ERCP pancreatitis. If you see the literature, there is evidence for ERCP induced pancreatitis, not for every pancreatitis. But yes, we do use when patients come with a little bit of worsening organ failures and acute pancreatitis with high CRP. Yes, that's an off-label indication. Yeah, so we have completed all the questions, and it was an interesting discussion we had. And we have touched upon all the points regarding treatment of pancreatitis, starting from clinical history, differentials, and fluid resuscitation strategy, nutritional strategy, and supportive care, and timing of antibiotic change, and imaging modalities. I think if there are residents who are appearing for critical care exams, I think this will have covered most of the topics pertaining to the pancreatitis management. I thank Dr. Sharmili Sinha for taking her time out of a busy schedule and joining today's masterclass. Thank you very much, madam, for your time.
Pleasure.
Yeah, and Dr. Balasubramaniam for having taken out his time joining from home from a busy drive back to home. Thank you, Dr. Bala, for taking your
Thanks.
time.
Thanks, Karthik.
Thank you.
And
All the best, Dr.
Thanks, Ram.
Ram and your colleague. Thanks
yeah.
everyone for
Thanks, and
joining. Yeah.
Thank
Nishala
you,
Krishna.
and,
Yeah.
Karthik. Yeah, so we come to
Chalo.
the end of the masterclass session. We'll meet again the next Tuesday with another interesting topic. Yeah, do stay tuned in. Thank you. Thank you all.
Thank you. All the best. Good night.
Thank you.
Thank you.